So I thought, well, that's interesting. And I did notice that she was pretty good at taking care of herself. You know, she hadn't had many falls. She wasn't getting sick that often. She was getting frailer, though. And so I took her in for a visit. I forget what it was for, a medication check or something like that. And I talked to Dr. Gabriel and said, you know, I'm pretty fascinated by your relationship with my mother, because she seems to be doing a good job of taking care of herself, and you seem to be empowering her to do that. How are you going about that? And so we talked about self-management support, and he said, you can't talk to Helen about these, you know, doing goal setting and action planning. He said, many of my geriatric patients don't want that kind of relationship. So I said, well, how do you get her doing it? And he said, well, for example, at the last visit, I do her clinical management, I do her medication management, and then at the end of the visit, I say, Helen, of all the things that are going on in your life, what's bothering you the most right now? And that's how he would end the conversation. In this case, she said, I'm worried about falling down my stairs because I wake up in the morning, I'm very wobbly, and I'm worried I'm going to fall. So he said, well, I can give you some advice. He said, I can teach you how to slide down on your bum and climb up on your hands and knees, or we could have a physiotherapist come into the house and do strength exercises and fall preventions. You could get a Stairmaster. And Mom at that point said to him, just tell me what to do. And he said, Helen, I can't tell you what to do. I don't live in your house. I don't know your life that well. You have to decide what is best for you. So she then went through the options. She said, well, I'm not sure I want to be sliding down on my bum during the bridge club. That'd be a little embarrassing. She said, I'm not crazy about having strangers in my house, so I'd rather not have someone come in, and I don't feel like going out to a physiotherapist. So maybe the Stairmaster would be a good idea. I guess that's a brand name, isn't it? I don't work for Stairmaster. Those things that take you up and down the stairs. So in any case, she settled on that, and he said, okay, well, how are we going to arrange for that? And she said, I'll talk to my kids and see if they can get that organized for me, which we did, and we put it in place for her. So after that, I said to her, I started talking to her about self-management support again, and I said, you see, Mom, what Dr. Gabriel did was actually empower you, give you advice, but you're the one that made decisions about your life and moving forward and taking care of yourself. And she said, don't be ridiculous, Michael. Dr. Gabriel fixes me. Stop telling me this stuff. What's important about this conversation is that Dr. Gabriel was able to do self-management support and empower my mother, yet maintain a relationship that worked for her. So I think a major part of what we talk about when we talk about productive interactions is we have to understand that our patients come from a particular point of view. And while you're doing this practice change, you're going to have to bring them along with it at the same time. Quite often when teams are doing more planned visits or group visits, they'll inform their patients that they're changing the way they're doing practice to improve the way they're delivering care. Patients are very receptive to that. They're very interested in the fact that you're trying to change what you're doing and that you're including them as part of the team. So that productive interaction is really what we're shooting for. So the remainder of what I was going to talk about, and I have to make sure I give Eileen a little more time, so we've been teasing Eileen up here. What I want to talk about in the last 15 minutes is what are the benefits of this change. Last night I talked about how to go about doing this and the kinds of things that you would want to engage in, but what's the real payoff for primary care? The reality is we keep coming at you and saying you've got to do this, you've got to have better access, you've got to reduce wait times, improve cycle times, improve your chronic care, do a better job of primary preventive screening. Here are the 10 things that you have to talk to patients about at every single visit, and we're just heaping this work on you. And we have to realize that not only do we have to make time for you to do that work, but we have to incent you to do that work. There has to be a payoff somewhere. Now, clearly, there are financial incentives that are coming from the ministry for doing certain procedures, certain primary preventive work. But I think the real payoff that I hear from teams and the teams that I've worked with over the last 10 years is how it's changed practice, and they're a whole lot happier delivering practice. So what do we know about the teams that have made these kind of changes? What we know is that the successful, high-performing teams are ones that actually function as a team. So everyone in the office is seen as part of the team. They're seen as being involved in patient care, right from the person on the phone in the front office right through to all of the providers. They work as a team, they meet as a team, they talk about quality improvement as a team, they review schedules and short huddles to prevent chaotic days, those sorts of things. The team is also prepared to deliver planned care in any kind of visit. So regardless of whether the patient shows up for an acute exacerbation of some sort or an injury or a short-term illness, you're prepared to deliver some of their chronic care during that visit, the care that maybe wasn't picked up at the last visit or something that was lost to follow-up. And you're also prepared to do specific planned visits where you call patients up proactively, bring them in to focus just on their chronic illness care, and leave all the symptoms behind, leave all the internet materials behind. And when you share that with patients and say, this will be how we'll structure the visit, we'll first focus on what your agenda is and focus on the provider's agenda, and we'll work through the issues in your chronic care, patients actually love that. And the call to do that is absolutely critical too. I mean, our dentists call us, our garage mechanics call us. I have 4 cats. I can't believe the calls I get from my vet. I'm pretty sure that my cats are better taken care of than me, and they probably know how to self-manage better than I do. And they get psychotherapy too, which I find fascinating. The other key thing is that self-management support is integrated into clinical care. Now, a lot of you that know about self-management support and teaching patients to be better self-care givers or self-managers tend to teach it in an add-on to what you do with clinical care. The two of them have to be integrated. Clinical care is quite often about physical care, medications, treatment planning. Self-management is about behavioral change, and all that behavior change has to be focused around the treatment plan, around the medications, because the reality is those treatment plans are so complex, the medications are difficult to take. You have to work with the behavioral part to help patients engage in their treatment planning. So self-management support has to be integrated into clinical care, not treated as something that you do over here or you do in a diabetes education center or you do solely with a health educator. Everyone on the team, as well as the allied professionals you work with in other agencies, need to be supporting the self-care of patients. Information technology has to be leveraged to facilitate care delivery. We have to have IT systems that actually help you do care better. Now, right now, a lot of electronic medical records here in Ontario, certainly south of the border in the States, are electronic versions of the old paper record. They have automated a record that is procedure-focused, is diagnosis-focused, and is not patient-centered at all. That looks backwards in time rather than planning forward in time. So it really doesn't help you with individual care planning that much. It tends to have just sped up the chaos of the paper record. What we need are electronic systems that not only facilitate individual care planning, but allow you to do shared care planning with a patient, plan into the future, but also be able to reach out to populations of patients. It's very important in order for you to track all of your patients to be able to go in and say, you know, give me all of my patients with congestive heart failure. Show me who I've seen in the last year. Have I done the needed interventions? Have I done the needed secondary prevention? Is someone working with them on their self-management support and teaching them about daily weights and salts? That kind of ability to drill into a population is extremely important, because then you can pull out the folks that are lost to follow-up. You can target the folks that are having a lot of difficulty and tailor your interventions to them. But with current electronic systems, you can only do things one patient at a time. So what we see in high-performing teams are ones that have IT, where they're able to leverage that population-based functionality, able to pull data out and see if what they're doing in terms of quality improvement is really making a difference. And then finally, high-performing teams are ones that have easy access and use community resources. And as I said last night, in the North, that is kind of a given. It's fascinating to talk to the groups up here in Northern Ontario and then talk to groups in Southern Ontario. The use of community resources in the southern part of the province is much less than what you do. You do it by definition. And I suspect, you know, my hypothesis about that is because you have scarce resources, you have people spread over large geographical areas, so you need to tie more into the community. What happens in the large urban centers in Southern Ontario, there's so many resources that most of the time providers aren't sure what's available, they aren't sure what's effective, and referral processes can be extremely difficult. But once you get tied into a community resource that is delivering diet, weight management, substance abuse, smoking cessation, or other lifestyle issues that put patients at risk, you find yourself delivering better care because you're then working with that resource, you're doing the clinical management, the patient is getting the support they need when they're outside of the healthcare system.